Thank you, Abha Gupta madam, and many thanks to Anita Saxena madam for giving this opportunity. I have two presentations. The first one is on the nutritional requirements in liver, and the second one on the luminal diseases. So, if you look at the paradoxes and diet in liver disease, on one hand, as Dr. Ghoshal has very elegantly shown us, on one hand, we have cirrhosis, where the patient is malnourished, emaciated, and we are encouraging dietary intake. On the other hand, we have non-alcoholic fatty liver disease, where the patient is obese and we have to restrict intake. And what is true for adults is the same for children here. On the other hand, you look at acute viral hepatitis, where, in India, there are a lot of dietary taboos. Families deliberately restricting everything. And a fourth component, which adults don't have, but in children we have, is metabolic liver disease, where the nature is deliberately restricting certain food items. And I'll show you the same. If you look at the liver and kidney diseases that are combined together, and there are some common conditions. There are some which present with glomerulopathy that like hepatitis B and C, Wilson disease on chelators, autoimmune liver diseases that have immunosuppression, and these disorders but present as hematuria or nephrotic-like state. If you look at tubulopathies, galactosemia, hereditary fructose intolerance, tyrosinemia, glycogen storage diseases, again Wilson's disease, all these present as rickets and growth failure. Then you have other conditions such as cirrhosis with hepatorenal syndrome, Wilson's disease with pigment nephropathy, primary hyperoxaluria, where the problem is in the liver, but the kidney is compromised with stones. You have rare syndromes like Alagille syndromes with renal dysplasias and Carrelli syndrome with congenital hepatic fibrosis, and they also have polycystic or medullary nephrocalcinosis. The nutritional requirements in cirrhosis, first problem is hypoalbuminemia, that is a part of your sarcopenia, poor muscle mass, there is edema, ascites, bone loss, and you can achieve that by giving a high protein diet, albumin, calcium. The second problem we have in children is a bile salt and fat deficiency, where children have weight loss, skin issues, night blindness, oral ulcers, all multivitamin deficiencies, and you can supplement them with medium chain triglycerides, fat soluble and water soluble vitamins. The third issue we have is high energy consumption that leads to fatigue and poor growth, and you have to give them a carbohydrate rich diet. There are some additional problems in cirrhotics. Patients have portal hypertension, they have blood loss, which is overt or occult. You have to give them iron and folic acid. Renal insufficiency, which is a very important component. Patients present with oliguria, ascites reaccumulation. There, fluid restriction, sodium restriction becomes the mainstay. Hepatic encephalopathy, where patients present with altered sensorium, and where you have to do protein modifications and branch in amino acids. The assessment parameters are many. You have clinical examinations, weight, height, Z-scores, body mass indices, mid-arm circumferences, triceps skin fold thickness, biochemical parameters, bone density, and CT to look at the psoas muscle thickness, and so many other parameters. And I will not go into all those because it's a topic on its own. These are some examples I wanted to show you. Look at these Bitot spots. We detected Bitot spots on day 1, and after 7 days, it cleared from the eye. These are very severe corneal ulcers due to vitamin A deficiency. Here is a child with hypoalbuminemia. You can see the leukonychia, half and half nail, where the tip of it is pink, but the bottom part is white. There is dry skin and essential fatty acid deficiency. This is rickets. If you can see, the bones are bent and the X-rays showing ricketic features. This is fatty liver disease, where you can see acanthosis nigricans and xanthoma. So these are the clues that we get. I'm sorry, my slides are not moving for some. So in acute viral hepatitis, like Dr. Ghoshal has said, the family restricts everything, and it's not right to restrict. We should give lavishly. And the nutrition advice that is given to the child ultimately leads to punishment for the child itself. Regarding neonatal cholestasis, we have to understand that 90% of what we eat are long chain triglycerides. Now, medium chain triglycerides are one such type of triglycerides which do not require any role of the bile salts and are directly absorbed into the system. These are C10 to C6 and they are directly absorbed into the portal circulation, and they give about 8.3 calories, and they are very good for weight gain. There are some commercial preparations that are available in India in the form of oil and powder and infant formulae, and I won't go into the details of the same. But natural dietary items contain a lot of MCT, such as coconut oil, which is 65%, and palm oil, which is about 54%. When you have to supplement neonatal cholestasis patients, you have to supplement with higher doses of fat-soluble vitamins A, D, E, and K than normal, and these values are all available over the internet. Water-soluble vitamins, the dictum is that you should double the dose and give it in cholestasis than what you give normally to children. Protein restriction in encephalopathy, on one hand, you need muscle mass. On the other hand, you'll end up with hepatic encephalopathy. So what is best is needs to be seen. If you look at the American Society of Liver Diseases recommendation, they are saying during an episode of overt encephalopathy, transient reduction of the protein is acceptable. But thereafterwards, once the encephalopathy has gone, then you should give about 1 to 1.5 grams per kg of protein. And you should not restrict because it will lead to sarcopenia in the patients. What is the choice of protein? So in the International Society of Hepatic Encephalopathy has said vegetable or dairy-based protein is a lot better than animal meat because animal meat contains a lot of sulfated amino acids that leads to mercaptans and indoles that precipitate encephalopathy. Plus, on the other hand, vegetable-based contains a lot of fiber and a rich source of fatty acid short chains, which are very good for energy. If you look at branch chain amino acids, then branch chain amino acids are leucine, isoleucine, and valine. And there is an imbalance with the aromatic amino acids in chronic liver disease. What happens is the aromatic amino acids are the ones that cause the false neurotransmitters which cross the blood-brain barrier and potentiate the hepatic encephalopathy. Hence, the trend is to give branch chain amino acids more than the aromatic acids. If you look at what the AASLD guidelines have said on branch chain amino acids, then they say that the branch chain amino acids is actually the second or the third line of therapy after pharmacotherapy. That means those patients who are refractory to pharmacotherapy are best managed by branch chain amino acid addition. And the dose of that is about 0.25 to 0.5 grams per kg in children. In cirrhosis and ascites, the problem is there is going to be salt intake. And salt intake, as you know, will give rise to ascites. If you restrict salt, the food is not palatable. If you stringently give salt, then you might lead to a lot of complications. So what is best? So again, the American Society recommends that during the time you have ascites, you must restrict the sodium at that point of time to approximately 88 millimoles per day. 1 gram of table salt contains 17 milliequivalents of sodium, and restriction of the sodium is about 1 to 2 milliequivalents per day in an infant and 1 to 2 grams per day in an adult. When you look at the sodium in dietary items, then as you see, the table salts, all your packaged and shelved products, bread, and all the other products contain a lot of sodium. Vegetables contain very little sodium, so that is well accepted. Now coming to the second part of my talk, the first part was on cirrhosis, and the second part, which is unique to children, is metabolic conditions. So the nutritional intervention in metabolic condition are of three nature. One is you target the ingestion, like in galactosemia, you want to give a lactose-free diet. In fructose intolerance, you want to give a fructose-free diet. Or you target an end product. For example, in glycogen storage disease, you can't make glucose, so you give cornstarch to make glucose. The third is to target a toxic product. Like in tyrosinemia, you want to restrict tyrosine and phenylalanine restrictions. Then you have a fourth and ancillary role that is supportive in addition to the pharmacotherapy, such as cholestasis as in medium chain triglycerides, Wilson's disease where you restrict the copper, ascites, you restrict the salt, and hepatic encephalopathy, you can supplement the branch chain amino acids. If you look at specific liver disorders and interventions in India, you have to see that age-wise, if you look, galactosemia and fatty acid oxidation defects are predominant in the first few years of life. In the later years, you will have Wilson's disease, glycogen storage disease, hereditary fructose intolerance, and citrin deficiency and urea cycle defects can actually present from any time in the childhood. When you look at Wilson's disease, you have to understand a lot of copper comes through our diet, and majority of the copper is actually lost in the feces. A small proportion is actually taken into the circulation and bound to the musculoskeletal system. What happens in Wilson's disease is you do not have ceruloplasmin, so the copper does not have any other compound to bind with and goes and deposits in the tissues. So what do you do in Wilson's disease? In Wilson's disease, pharmacotherapy is the first choice. Dietary copper is just ancillary. But nevertheless, dietary copper is important. These are some of the dietary items that contain a lot of copper, and AASLD says that you should avoid them in the first year of therapy till the time you're giving proper chelation. Then afterwards, there is no stringent restriction of a copper-restricted diet. And in the drinking water, the supply needs to be a little less with copper. We concur with the same, and I would suggest you can read this Wilson's disease guidelines that we have published in the Journal of Clinical and Experimental Hepatology in 2019. And in that, we concur with what they have said, except for the fact that in India, the dietary copper content as per the National Institute of Nutrition is a little different than what we have in the West, in America and other places. In our country, the red gram and the soybean are the ones that contain a lot of copper. The rest of the lentils actually do not contain so much of copper. And all the other items that you see here are taken in such small quantities that actually speaking, they are not containing high copper content. So the rest of all the items in India, as per the National Institute of Nutrition guidelines, they say that the copper content is not too much in our food items. Now, the next condition we look at is galactosemia. Galactosemia is a condition where the patient does not have the galactose-1 phosphatidylinositol transferase enzyme. So he cannot metabolize the galactose, and the galactose becomes toxic and gets deposited in various parts of the body. So what you need to do is give a lactose-free or a galactose-free formulation. Now, in children, that becomes a major issue because you're stopping milk from the diet. Now, to undo that and to supplement that, you have various permutation and combination. You can give a casein-based formula, but that's not recommended because that gives a lot of galactose in the body. So what do you have? You have a soy-based formula. Soy-based formula contains very little galactose, but the problem is soy, as I will show you in the next set of slides, soy is not recommended less than 6 months of age, and galactosemia is one such condition which presents from the neonate up to 6 months of age. So what you have left with you is a hydrolyzed formula that contains very little and negligible amounts of galactose. Now, galactose-restricted diet, you can restrict fruits and vegetables, but you see fruits and vegetables do not contain much of galactose as much as it would actually harm the patient. Endogenous galactose production is much, much higher, and hence this is much more toxic. So people question how much vegetables and fruits should we restrict? You see, for you to have a very severe disease, you must eat 600 mg of galactose per day to get a very severe disease. 600 mg of galactose is equal to 7 apples, 2.5 kilos of tomatoes, and 12 grams of peas. Now, in a normal diet, we don't eat that. Hence, in galactosemia, it is not useful to restrict fruits and vegetables. I would also again suggest that there is a paper we've published on galactosemia, and we've looked at the long-term outcome of the same. And in that, we have seen that those patients who have been compliant on a lactose-free diet have actually done very well in follow-up. A very small proportion have some significant developmental delay, but the liver becomes totally normalized. This is a Galactosemia family who's been following up with us for years together. And the family wants to actually, they are with us wherever we promote Galactosemia. This is the index boy. The first 3 children died. This is the index boy who is now grown up, and now he's actually 10 years of age. And you see how well he has become on lactose-free diet. And this is the asymptomatic sibling. The father always pleads to us that please spread the message of Galactosemia in the almost in all across India. Glycogen storage diseases, the major types in children are type 3, type 1, and type 4. Here, not a lot of glucose is produced and everything gets stored. The mainstay of therapy is cornstarch, and cornstarch is containing alpha 1 and alpha 1,4 and 1,6 bonds in the ratio of 1 is to 20 is to 1. And what happens is when you give this cornstarch, the salivary and pancreatic amylases break down the alpha 1 and 4 linkages, and the brush border enzymes slowly, one by one, like chopping in a factory, it breaks the alpha 1,6 linkages. The cornstarch therapy is a complex starch with low glycemic index. It has slow digestion with sustained glucose release. You can give it as a nasogastric drip or infusion pumps if the patient has severe hypoglycemia, or you can give it intermittently, which we do in our setup, 4 to 6 hourly, and this is recommended in children. The dose is 1.75 to 2.5 grams per kg per dose, and this should be indigenously brought, not the packeted cornstarch, uncooked and dissolved in cold water. The other dietary modifications that we do for glycogen storage disease is in DSD1, we restrict the sucrose, that means you don't give the table sugar, and the lactose, that means you don't give milk. And we give, in GSD3, we do not have this restriction, but we give a lot of protein, 3 grams per kg, because this is a disease that has inherent muscle breakdown also. Hereditary fructose intolerance, this is where the fructose does not get metabolized, and hence it causes hypoglycemia. And there, the patient, because of the fructose load, has GI symptoms such as vomiting and diarrhea, and may also have liver symptoms. It can be anywhere from deranged LFT to acute liver failure. Patients have seizures and hypoglycemia. The dietary therapy in that is, other than the fruits and fruit juices and table sugar that we restrict, we also restrict a certain degree, a certain amount of vegetables. But what is allowed is glucose powder, lactose, and all the meat and fish and eggs. Tyrosinemia is again a very complex condition where after a certain point of time, there is a enzymatic problem, and that leads to hepatotoxicity and neurological crisis. And in that, again, there's a dilemma. On one hand, we need phenylalanine and tyrosine for body growth, and at the same time, this phenylalanine and tyrosine gives hepatotoxicity. So what we do is we block it with a pharmacological agent known as nitisinone, and then we do a dietary restriction. So the dietary therapy is in an acute crisis, you're giving a tyrosine-free, phenylalanine-free diet. And then once the levels are falling, you introduce the breast milk and the infant formula. And you titrate in such a way that the plasma tyrosine and phenylalanine levels come to a normal level, and then you give a tyrosine and a phenylalanine restricted diet. And it has shown that this sort of a dietary therapy will also improve the renal tubular function in these children, but it may still continue to give hepatocellular carcinoma in the long run. So in conclusion, diet and liver disease, if you look at, on one hand, we have science, we have therapy, we have diets, which reduce the morbidity and mortality. But comes with a very high price. There is cost. It is a problem of palatability, comfort, compromise, and quality of life. Thank you.